I mentioned briefly continuous renal replacement therapy, and this is a diagram of how that therapy works. And the sort of ball in the middle of the diagram is a series of filters and pumps that moves the blood through from the circulation of the patient into a machine. And in the machine, the blood is filtered and materials that are in excess, such as nitrogenous wastes, are removed, just like the kidney would do it. But it's done slowly and continuously. So this is a 24-hour process. It's on all the time, and the nurses have to monitor this and make sure that it's working appropriately. This has caused an improvement in acute renal failure outcomes. And often complete recovery. So patients recover completely and do not have to go on hemodialysis necessarily after they're discharged from the ICU. And this has really improved how patients feel afterward as well, because hemodialysis is not fun. And if you can keep people off of it, it's a big plus in their lives. This is a large left ventricular assist device, a bedside one. These devices actually can be quite small and can actually be basically in the chest with a pack that you carry at your waist, and you can go home with them, but that's not a common situation. The left ventricular assist device is placed by a cardiac surgeon. It has a balloon that inflates during cardiac diastole. So when the heart is relaxed, the balloon in the left ventricular assist device inflates. And we'll see in a subsequent slide that this actually increases diastolic pressure in the aorta, which improves coronary blood flow and improves oxygenation of the heart. So that's good for the heart muscle. Then during cardiac systole, when the heart contracts, the balloon in the left ventricular assist device deflates. That unloads the pressure against which the heart has to work, improves cardiac output, and produces less work for the myocardium. This kind of device is often used to stabilize patients prior to cardiac surgery, and it can actually be used, as I mentioned earlier, as a bridge to heart transplant. And the smaller devices that can be implanted are used temporarily as artificial hearts, and people can use them for up to several months before they start to have problems with them. And this is a diagram of how this device works. You can see that the balloon, which is the gray device in the aorta, comes all the way up almost to the heart, just to where the left subclavian artery comes off. And it inflates during diastole, increasing the pressure in the blood close to the heart, forcing it into the coronary arteries and improving myocardial oxygenation. And then during cardiac systole, it deflates, so that the pressure against which the heart is working is markedly reduced, and the oxygen demands of the heart are reduced. And sometimes this can result in complete recovery of the heart. The ECG is modified, and you have to learn how to utilize this device, and you have to learn how to set the device to inflate and deflate at the right times. If you're off by even just half a second or so, you can cause a lot of problems. So it takes highly skilled people to use this thing. So systemic inflammatory response syndrome is a relatively new diagnosis, although it's been around for a long time, and it's often but not always associated with sepsis. It's part of a syndrome that may lead to septic shock and death, but not always. It's associated with a general breakdown of the body's immune system, with the development of generalized tissue inflammation, and we really don't understand this process. It's not always related to infection, but in a non-specific response to ischemia, loss of oxygen, trauma, inflammatory processes, or infection. It's part of a continuum and is often seen as the presenting condition of this problem. So the diagnostic criteria for the SIRS continuum are SIRS, sepsis, and septic shock follow this pattern. For SIRS criteria, you need two criteria, either a temperature greater than 38 degrees centigrade, a heart rate greater than 90, a respiratory rate greater than 20, or PCO2 of less than 32. In other words, the patient's really working at breathing, and a white blood count that's greater than 12,000. So you need 2 of those to make the diagnosis of SIRS. To take the next step and make the diagnosis of sepsis, you need to have SIRS plus a source of infection. So you either have to have a suspected source or be able to prove that you've got a source of infection. The next step is severe sepsis. And this is when organ dysfunction begins to intervene, low blood pressure, and decreased perfusion of organs. And this is characterized by lactic acidosis, which is measured in the blood, systolic blood pressure of less than 90, or a great drop in systolic pressure. So those things in combination define severe sepsis criteria. Septic shock is the next step in this very bad condition. This is severe sepsis with hypotension despite adequate fluid resuscitation. So in a situation where you're sure you've fluid resuscitated adequately and you still have hypotension, you've got severe shock criteria. And then the final stage of this, prior to death in many cases, unfortunately, is multiple organ dysfunction syndrome. So everything above plus the evidence of more than 2 organs failing. So cardiac, respiratory, renal, any 2 organs, often liver failure at this point. Treatment is very aggressive and starts with early antibiotic therapy. Every delay in administering antibiotics increases mortality by 8%. That's an amazing statistic. A 1-hour delay in starting antibiotics increases the likelihood the patient's going to die by 8%. Effective hemodynamic support is essential but difficult. The current drug of choice is norepinephrine, or noradrenaline is the other name for it, and it's given intravenously, obviously, but in very high doses in some of these patients. The third step is effective volume management. This is also important to use the best fluid replacement substance, and this is very controversial. So artificial colloid, albumin, normal saline, balanced salt, high concentration saline, 3 or 5% saline, which are the right agents to use, or hypotonic solutions. It's all extremely controversial, and it has been for 40 or 50 years. I've read documentation from after the Second World War showing that the right fluid at the right time has been a challenge for medical people for a very long period of time. The best fluid is not known, but maintenance of normal or slightly high central venous pressure appears to be the best path, irrespective of the fluid used. So we're now going to step away from SIRS and sepsis, and we're going to talk about general management of the patient in the ICU, including sedation, pain control, and muscle relaxations. Muscle relaxation should be used with great care in the ICU. It is very easy to produce immobility in the presence of awareness and pain. If they are used at all, a peripheral nerve stimulator must be utilized to assess the degree of paralysis. The major reason for using paralysis is to minimize the body's oxygen demands. When the muscles are all paralyzed, the oxygen demands in the body drop dramatically. So it's worth doing in some cases, but you have to be careful with it. And you have to remember that muscle relaxants produce no amnesia and they produce no analgesia. Pain management is usually done with a continuous opioid infusion, but this has to be carefully done, particularly in the presence of renal failure, because complications can occur because the metabolites of the opioids are not removed by the kidney. Sedation drugs range from benzodiazepines such as midazolam, lorazepam, the old Valium, anesthetic drugs such as propofol, sometimes ketamine, and central alpha-2 agonists, drugs such as clonidine, which has been around for a long, long time, and dextrometamidine, which is a very currently very aggressively marketed drug, which seems to be an excellent drug in some situations for sedation. Patients in the ICU require sedation pauses on a regular basis. And the reason for the sedation pauses is to give them a chance to wake up, give them a chance for the nurses and doctors to assess their ability to recover and to see what level they're at with recovery. No sedation mode has been shown to be superior than others, but some, as I mentioned, dextrometamidine, are very aggressively marketed. So sedation in the ICU is titrated to the Richmond Agitation Sedation Scale, or RASS, Richmond Agitation Sedation Scale, throughout the time that they're in the ICU. So I'm going to let you look at this slide and go through the various numbers. I'm not going to read it to you. It's easy to see how the scale is calculated. And by reading through this and understanding it, you'll have a better idea of how sedation is managed and what level of sedation is considered to be a normal level. Patients often spend extended periods of time in the ICU, and they can't eat. They're usually unconscious or paralyzed or heavily sedated. So nutrition becomes a major issue. And it's a very complex topic, and we can't cover it in detail in these talks. But the bottom line is that nutrition is given enterally through the gut, if possible. And this can be either by an oral gastric tube that goes through the mouth down into the stomach, or even out, preferably out into the duodenum, or a nasal gastric tube. And fats, carbohydrates, and protein can be delivered this way, and the normal digestive factors of the human being are utilized to absorb and use these agents. This is far and away the best way to feed patients in the ICU. Early enteral nutrition improves outcome in critically ill patients, and we've only known that for a few years. So it's part of the normal treatment in the ICU now. Nutritional treatment can be given intravenously by a central line directly into the circulation system, but this is a complex process and is often complicated by infection and inadequate calorie delivery. It is not the first choice. This is a very controversial topic. We basically don't do a great job of nutrition support for patients in critically ill situations. One of the unpleasant aspects of intensive care treatment is that there's a reasonably high mortality rate in the intensive care unit, and there needs to be a way of determining brain death. We have very sophisticated means by which we can keep the heart functioning, and so pure heart death is now not looked upon as the only means by which we determine death. But each country has its own legal criteria for determining neurologic determination of death, or NDD. And I've only mentioned the Canadian criteria here. You need to check your own country and make sure your criteria are understood. So in Canada, the minimal clinical criteria for neurologic determination of death are an established etiology, so you have to know what's causing the problem and be able to say that that particular etiology is capable of causing brain death. Deep unresponsive coma with bilateral absence of motor responses, excluding spinal reflexes. So some reflexes will remain, but no response to pain or position sense or any of the usual things that one responds to when normal. There have to be absent brainstem reflexes. So that may be response to corneal stimulation, loss of gag reflex, loss of cough reflex. So the corneal response goes both eyes, pupillary responses to light, so the pupil changing size according to different levels of light, and vestibulo-ocular response, which is done by looking at eye response to usually putting a cold solution in the ear canal. The eye should vibrate, which would indicate normal vestibular-ocular response. If nothing happens, that's a very bad sign. An apnea test is done. The patient is discontinued from the ventilator, but this can only occur in a situation where there are no muscle relaxants on board and where there's virtually no narcotic on board. You turn off the ventilator and you give the patient a period of time, usually around 3 minutes, to see if they make any breathing effort. And then there has to be absent confounding factors, as I've indicated. So sedation, deep sedation, muscle relaxation, heavy use of narcotics can't be in place at the time that one determines neurologic death. So at the time of assessment of NDD, the following confounding factors preclude the clinical diagnosis. So if any of these things are actually in place, you cannot legally, at least in Canada, make a neurologic determination of death. So if there's unresuscitated shock, or if temperature is low, below 34 degrees, and it's a bit of a joke, but it's a legal requirement that you cannot be cold and die. You must be warm and die. Severe metabolic disorders capable of causing a reversible coma must be excluded. Severe metabolic disorders including glucose, electrolyte, and unusual electrolytes such as phosphate, calcium, magnesium all need to be checked, and it has to be determined that they're at normal levels. There has to be an examination to make sure that there aren't inborn errors of metabolism that might mimic death or coma. And you have to make sure that you're absolutely convinced that everything that could mimic coma or death has been eliminated before you can make the neurologic determination of death. So certainly things like drug intoxication, alcohol, barbiturates have to be absent at the time you make this determination. So in summary, in this lecture we've discussed the intensive care unit, the various forms of intensive care unit that are present in our society now. We've talked about the training required to become an intensive care physician and the special skills that nurses require to work in intensive care. We've talked about some of the diagnoses that are critical in the intensive care unit and some of the equipment that's used to try to support patients in the ICU. And finally, we talked about the neurologic determination of death, which is a legal definition of death and is determined by individuals' countries and varies from one place to another a little bit, not a lot, but a little bit. So it's important that you understand your own country's neurologic definition of death.